Hey, Maush.
Hi, Nita. Are you able to see my presentation?
Yes,
Perfect.
totally. Thank you for doing this. I'm excited.
Yeah, my pleasure.
Maybe just give it a minute or two, and then after that, you can start whenever you're comfortable starting.
Sounds good. Okay, so I think we've got most, if not all of the fellows on right now. So I'll get started. So today I'm going to be talking about managing social determinants of health in the sleep clinic and briefly, no financial disclosures. So in terms of our agenda items for today, we're going to define what social determinants of health actually are and review what different key elements of a patient's health might be affected by the five main social determinants. We'll explore how these social determinants can impact specifically sleep health, and then discuss strategies for addressing social determinants of health in sleep medicine clinics. And then I'm also going to highlight how Michigan Medicine and our Sleep Disorders Center are addressing some of these social determinants of our health to promote health equity with our patients. And just as a disclaimer for number four, Michigan Medicine as a community and our sleep department engages with social determinants of health in many different ways. So the examples I have today are not exhaustive by any means. And if anyone has certain resources that I haven't brought up that they're aware of, please feel free to share those in the chat or unmute and share them because this is a good space to collaborate on what we can do to promote health equity in our clinic. So, to define social determinants of health, these are conditions in our environments, whether it's where we work, where we live, where we play, go to school, learn. These all affect an individual's health and their quality of life. And there are five key social determinants of health. These are ones that have been highlighted in prior lectures, especially with Dr. Billings' lecture a few weeks ago about health disparities in sleep. But to review, these are healthcare inequality, neighborhood and the built environment, social community context, economic stability, and education access and quality. So to review examples under each of these categories, healthcare inequality includes things like a patient's level of insurance coverage, whether or not they have many copays or high copays with return visits or specialist visits, whether or not they've got access for transportation, gas money to get to their healthcare appointments or facilities, how comfortable they are with engaging in the healthcare field or with their physician's office, what's the level of health literacy that might affect their comfort in engaging in the healthcare field. And then also, what are their providers' availabilities and what access do they have to quality of care? Relating to that, a patient's neighborhood or where they reside primarily significantly impacts their healthcare as well. So, patient's housing location, how close are they to healthcare facilities? How close are they to a bus station or a place that they can get discounted or free transport? How walkable is their neighborhood? What is their perceived level of safety in their neighborhood? Do they live in a place that has access to things that promote physical activity or wellness, like recreation areas or parks? And how is their access to healthy, nutritious food? Social and community contacts, kind of like it sounds, it's all about the patient's social supports and their community level of integration and engagement. Do they have support systems in place that can help them navigate health issues? Do they have increased stress, whether that be because they're not part of a community or as a result of their community? Or do they face discrimination in some way in the community that they identify with, and that can significantly impact their overall health as well. Looking at economic stability, so, is the patient's employment stable? Is their level of income stable? What's their debt to income ratio? Do they have a lot of medical bills? Do they have access to get support if they do have medical bills or payments that they're having difficulty with meeting? And then finally, education access and quality. So things like a patient's level of education, their overall literacy, is the language that they prefer to speak in or that they're fluent in the same language that their provider is speaking to them in, or do they have resources to help them engage in the healthcare system with all the jargon that we might be saying on a day-to-day basis? And then do they have early childhood education programs that might be available for their kids if they need extra support to have ultimate success? So all of these key factors funnel in to affect a patient's health, well-being, functioning, their health outcomes, and their health risks. So it's pretty important to see how we can address some of these. And I'm going to now go into addressing each of these and how they might impact sleep health. So we'll start off with healthcare access and quality. So I'm sure a lot of us are very aware of difficulties with access, not only in our sleep clinic, but in general. Through Michigan Medicine, there is a huge challenge for access from a patient standpoint to get in to see their providers. These challenges might be from lack of insurance coverage from a patient standpoint or inadequate insurance coverage, especially for specialty visits. There's a shortage of sleep specialists, and to add to that, technologists, respiratory therapists, and the Journal of Clinical Sleep Medicine in 2020 actually published that the estimated patient to sleep physician ratio at that time was 43,000 to 1. So pretty profound, and the need is definitely there for more sleep physicians. And then the Society of Behavioral Sleep Medicine directory, which is a great resource for providers and for patients to help find sleep psychologists, especially those who are trained in CBTI for sleep insomnia concerns. That lists about 434 members in the US as providers who are available for sleep-related concerns. And so that number is even smaller when we think about the number of patients that have need to see our sleep psychologists and members of the SBSM. In addition to just access issues with the number of providers and insurance concerns, there's also just a sheer underdiagnosis or underrecognition of sleep-related concerns, especially in primary care offices, and that can lead to delays in treatment. And obviously, unaddressed sleep-related issues have a significant impact on a patient's overall health. But we also see that there are chronic conditions like mental health conditions or underlying chronic pain concerns. If they don't have access to see those specialists, then that trickles down into poor sleep as well. So it's all related in terms of a patient's access to healthcare and their sleep. So here are some potential solutions that we could use to improve sleep clinics access. So offering telemedicine visits, especially since the COVID-19 pandemic, have been much more utilized. And for the most part, for patients who enjoy engaging in video visits or phone calls with their providers, they're very much appreciated. Outreach for education on sleep disorders and screenings, whether that be, in different community groups like nursing homes or in schools, or, with primary care offices who might be the first to actually hear about sleep concerns or might be the first to actually bring them up with their patients. And then, of course, low cost or free of cost clinic options, especially in underinsured or uninsured communities. So to see how U of M is kind of measuring up with these potential solutions, I've included a block M if these are things that we are implementing, either in our department or as a community in the Michigan medicine system. So obviously telemedicine visits we offer at all of our clinic sites. And a lot of my patients say that they prefer video visits, especially if they're from a smaller town up north or, driving more than 2 hours to get here overnight. It's very costly in terms of gas money, or if they have to spend the night at a hotel to be there for an 8 a.m. appointment. Patients also have a little bit of anxiety that they report about, having to find parking at the main hospital, which is very understandable, or having concerns regarding being in a big city like Ann Arbor and having to navigate around here when they're not used to that. They might be from a smaller community. So that's definitely a patient-forward solution. Additionally, we see that there's a lot of outreach that our department and faculty have done, not only for patient-focused outreach, but also within departments. And one of the examples is Coursera modules that were recently published by our faculty here, which is excellent for patients and even providers to learn about sleep health and sleep disorders. There are other ways that even I've, as a primary care physician who's trained here, engaged in, just curbside in baskets about what should a primary care physician do with the result that they weren't sure, how to order a BiPAP ST or, ways to engage and to allow primary care physicians to come to a sleep specialist and feel comfortable with asking questions that they don't necessarily want to refer a patient for. And then the low cost or free of cost clinics, our Hope Clinic in Ypsilanti, where we provide care for free on Saturday mornings is an excellent example of that as well.
To clarify,
But
that's not University of Michigan. I mean, we're doing it, but right, I don't believe it's actually supported by U of M.
for,
Hope Clinic,
yep,
it's
yeah,
independent.
yeah, it's our faculty that are going over there, some of our faculty, but it's not our clinic. All right. And then going on to neighborhood and the built environment and ways that that can impact sleep health. So there's a lot of research that's been done about housing location, neighborhood conditions, and we found that poor neighborhood quality is associated with poor sleep quality, where patients who are in higher levels of crime or neighborhoods experience poor sleep efficiency and longer wake after sleep onset. And then patients who have a greater perceived sense of safety have higher sleep efficiencies and shorter wake after sleep onset. And I think that is something that we might see in our veteran population or patients who have history of PTSD or any type of sleep safety related concerns. And a lot of these patients might have poor sleep quality overall because of the sense of hypervigilance in their community. There's also a big component of food access and exercise or recreational facilities and access to those, where if a patient is in a lower socioeconomic status neighborhood, they might not have adequate exercise spaces and nutritious food options and might be living in what we call like food deserts or exercise deserts. And these patients have a higher prevalence of chronic conditions such as obesity and diabetes, heart disease, and we see the close relationship these have with sleep apnea and how sleep apnea can also negatively affect these. And then noise and light pollution is another big factor that can affect patients' sleep. So environmental traffic noises can increase N1 sleep, and they can also decrease N3 and REM sleep. So overall, poor sleep quality if you're in a more environmentally noisy environment. And then looking at solutions to potentially address these, patients are able to access, if they have the resources, offering them, housing, transportation, or food support services, having community outreach within urban planners or policymakers, and in that realm where we can try to optimize urban design, see if we can create noise barriers, especially in places that might be overcrowded, and seeing if we can improve traffic management in residential areas to address some of that noise pollution as well. And then some potential provider-specific opportunities, just, being aware of a patient's excess funds that they might have to put towards this. And if they don't have funds, maybe just becoming aware of low cost or free of cost environmental modifications or ways to optimize a patient's sleep environment, whether that be, a free app on your phone that allows for white noise or brown noise, having door stoppers where they cover the light that comes through the door or noise that can come through the door with like a foam roll. These types of things can be pretty cost effective and improve sleep health overall. And then in terms of resources available here, we do have guest assistance and social work programs that can offer patients housing, transportation, and food support services. And I'll talk a little bit more about that towards the second half of my presentation. But I'm not personally aware of any community outreach with urban planners that the, neurology department or sleep department is currently working with. That could be potentially something as a way to overall improve our patients' sleep environments too. Talking about social and community context. So there was an interesting study that was done back in 2023 that was a 4-year population-based prospective cohort study looking at adults ages 50 and older. And they found that in these adults, loneliness was associated with the onset of sleep difficulties, whether that be, initiation difficulties or maintaining sleep, leading to early morning awakenings, and overall sense of non-restorative sleep. And that was despite the fact that these patients might actually, belong to a community, but it was the perceived sense of loneliness that led to their sleep issues. And then discrimination-related chronic stressors can definitely affect a patient's sleep, whether that be discrimination based off of race, sex, how they exhibit their gender expression, or who they choose to love. All of these things, especially multiple discrimination events, can lead to increased hyperarousal, difficulty with sleep onset, maintenance, and also shorter self-reported sleep duration. And then cultural beliefs and values are a big part of some of our patients and their sleep beliefs as well. So in a society that might prefer more interdependence, there could be a culture of like collective naps in the middle of the afternoon, especially in areas outside of the US where there might be like an afternoon siesta and it's very appropriate to close down shops or just, rest for a little bit in the afternoon. In patients' lives where they might be in a joint family system or there's more of like a group effort in like raising children, they might have a little bit more support, especially at nighttime where sleep might be more fragmented in infants and toddlers. And then, that's very different from a society that might be more independent, where someone's sleep related concerns or any mental health concerns that are affecting their sleep are thought to be more private, and they might seek help, independently and might not have as much support in the home, or might not want support in the home to address these things. So looking at potentially addressing social and community factors, collaborating with other team members. So sleep psychologists, mental health providers, social workers, these can be very helpful, especially if we, in our evaluation, are noticing underlying themes like insomnia or mind racing, rumination, underlying anxiety or depression that might not be addressed, things like that. And then culturally forward sleep education and training, and working to really have a mindset that, looks at patients' cultural beliefs around sleep. And some examples might be, if a family is a really big part of a patient's sleep, or they're really influencing their sleep and their sleep habits, then family participation in education can be really valued. And then recognizing the role that religion might play on sleep routines can also help prioritize sleep practices that would promote good sleep, but also prioritize the religious practices that might be important for patients too. And then, of course, there's always professional development opportunities to help mitigate, identify, and, address our own possible biases or implicit biases. And for U of M, I believe we provide all of these things. So we've got an excellent network of providers who can help, and we can, we have access to them. We can do soft handoffs with them. And as someone who trained here for fellowship, I definitely feel like my training was culturally forward, especially in the peds sleep department, where a lot of the parents might be involved directly in their sleep beliefs and what they might be doing and how that might be negatively affecting the patient or the child's sleep habits as well, and really trying to meet the families where they're at and find sustainable solutions for them to implement in their bedtime routines. And then in terms of professional development opportunities, the Office for Health Equity and Inclusion has self-guided modules to identify some biases that we might have. And these are some training courses that are provided through them, where, we can look at biases even when we're hiring peers or colleagues, and then looking at, building toward belonging when we're looking at our own biases, or what we believe might affect patient care as well. So those are opportunities that are out there within the U of M community. And then moving on to economic stability. So not surprisingly, any type of financial hardship or difficulty is going to affect sleep negatively. So there is evidence that financial hardship identified by patients does seem to be associated with reported poor sleep quality, greater risk of insomnia, and these patients are also less likely to meet minimum sleep duration guidelines, so that minimum 7 hours. And that is multifactorial. If they're having difficulties with meeting utility bills and they might be working multiple jobs, or if they have difficulty with coordinating childcare, they might be, working night shifts. And so with that, if a patient is working irregular hours or multiple jobs, they might have limited access to care in clinics that work or operate during conventional work hours. They might also have inadequate time off between shifts, where they're, seeing us in clinic in the morning at a time where they should be sleeping. There are a lot of times where childcare comes up when it comes to, considering an overnight or an in-lab sleep study. And even, for home sleep tests, if a child is frequently in the patient's bed, or, might be disrupting or interrupting the sleep, that can affect our quality of the study as well. So that's something to consider. And then patients also report, just difficulty with being able to have pay for their copays for their CPAP machine or the supplies, or not being able to afford a medication that we recommend. And I just had a 20-minute conversation with a patient yesterday about how her Sunosi is $200 a month, and that's not something that's reasonable for her. And we also have had patients who have difficulty accessing their medications. So with stimulant shortages, or some pharmacies that might not have the medications in stock. These are additional barriers that can prevent patients from actually getting the medications that they need, or having to travel further to get medications that they need to function on a day-to-day basis.
Can I chime in for 1 sec?
Yeah.
I mean, this is so important. I was just talking to one of the fellows today, like with Medicaid, where they get 1 mask a year. And, of course it's going to leak. Of course it's going to affect compliance. And, of course, they also may not have money to self-buy a mask to extend, the utility of it.
Yeah, absolutely. Yeah, thank you, Shelley. That's a great point. So how can we potentially address these when they come up in the sleep clinic? Well, financial assistant programs are definitely helpful, and we are very lucky to have those here. Tools to navigate health insurance or to help patients see if there are other, low cost options through their health insurance, or maybe pharmacies or medications that are better covered through their prescription program. We have opportunities for patients to, potentially get like discounted machines or refurbished machines, and that can take away some of the financial burden of having a CPAP machine and having to pay for it. And then, we can work to facilitate an environment that promotes healthy sleep habits, and whether that be, going to different employers and promoting, adequate time off, or even, doing that here within our own community to try to practice what we preach as well. And so U of M does have financial assistance programs available for patients, and we do have ways to link our patients with these programs, and I'll talk about that in a little bit too. But in terms of, CPAP banks or refurbished machines, I know there's a DME company that takes old machines that are still functional and then also provides them to patients as well. And I've had patients ask me, they have gotten so many refills on supplies, and they have all this tubing and these unused masks, and they don't know what to do with them. And these patients, I encourage to, contact the DME company that I know of, that helps with, providing supplies for our patients, and hopefully having a way to repurpose the excess supplies that they're not using, or an old machine that they are no longer using, but that's still functional. And then in terms of facilitating a work environment that promotes healthy sleep habits, the I'm Healthy group actually sent out an email last week, which I thought was very timely. It's their Sleep Well, Be Well newsletter that's coming out next week. And it's ways for us to prioritize our sleep, get better rest, and this is all in line with upcoming daylight savings time. So I thought that was really helpful, and a plug in case you're interested to register for that and have gentle reminders of how to prioritize your sleep. And then finally, education, access, and quality. So lots of educational barriers that are present in sleep health. There's potentially, a lack of public awareness regarding sleep disorders, sleep's importance. Sometimes I feel like the public doesn't emphasize sleep as much as it should be. And there are just, not many patients who are aware of the chronic habitual snoring and stopping breathing as a problem, or their, restless legs that, they have to move at nighttime, and it might prevent them from falling asleep. It's been happening for so long that they didn't even realize that it might be an issue that could be addressed. So if patients aren't aware of their symptoms and aren't able to, talk about them or bring them up in their initial evaluations with PCP, then that leads to just delays in seeking care, diagnostic testing, and ultimately treatment. I've noticed there's a lot of misinformation or just like sleep myths out there as well, especially in social media. I was just reading about like sleepy girl mocktails with magnesium powder and like a tart cherry juice or something, and that's being promoted on TikTok as like a way to help promote sleep. And there might be some evidence in magnesium and sleep promotion, but a lot of times, there's a lot of fact checking that needs to be done, especially when social media is providing sleep education for younger patients. And then there's also just limited integration, especially in my experience, in schools and sleep education, in a patient's work environment, and then also in the PCP's office. And as someone who trained here for residency in family medicine, I can say that, I really did not have any direct sleep medicine education until I sought it out myself. So that's definitely a place for improvement as well. And then when we look at individuals in general, if they have lower educational attainment, then they're more likely to experience poor sleep quality and shorter sleep duration. And then the opposite of that, for patients who might be seeking higher education, they might prioritize academic demands over sleep. And obviously that is something that isn't good for cognitive performance. But there's again some misinformation out there, maybe a culture that, you know, you can sleep when you're dead, or, you know, that it's better to get that A than to get an extra hour of sleep. And that might be the culture, and especially high functioning or type A type of personalities. So potentially addressing educational barriers, patient education handouts, especially at appropriate literacy levels, so they're easily understandable without a lot of medical jargon, use of interpreter services, especially in a patient's preferred language, and if it's different than your own, and you don't feel comfortable relaying information and medical information in that language. Offering group education sessions, whether that be, again, in the community, in schools, at health fairs, or even through, you know, conferences, and also, you know, within our departments. So personally, I'm really happy to like offer didactics to the residents over in family medicine, and you know, present at their grand rounds about sleep related topics, just to raise awareness about common sleep disorders that they might see and how to initially diagnose or treat. And then disseminating sleep promotional education in the community can also be beneficial, whether it be, you know, flyers on campus about sleep health and promoting wellness overall that can improve sleep health, and then increasing accessibility of sleep health knowledge on mobile apps. And that's something I think is a very growing field. I know that there are a lot of apps out there like Calm, Headspace, things that help you kind of figure out what to do to optimize your sleep and promote good sleep habits. And here at U of M, I know that we've got at least the first four. As far as, you know, mobile apps, I don't think there are any currently. I know in the past some faculty have created mobile apps specifically for research trials, and, you know, maybe tracking sleep, but it's definitely an area of growth, and where we can engage and potentially make a profound difference too. So even though we've got the social determinants of health, you know, kind of identified and potential ways to address them, there are still barriers out there for implementation. And I think the biggest one that we can think of is just like resource constraints. So time. When we're doing a sleep-focused evaluation, it can be difficult to address the patient's social needs in addition to our sleep-focused evaluation, or you might not even know what to do when a patient recognizes that, you know, when you're doing a substance review with a patient and they're saying that they're drinking, you know, 6 or 7 drinks a night, and how that can be problematic, but you're not necessarily sure how to actually get them engaged in services to promote alcohol cessation. And then there's also difficulty just finding, you know, people that can aid in that too, whether that be social workers, therapists, or community resources, to really focus in on providing multidisciplinary care. And then beyond that, there's also just the policy barriers. So there's limited insurance coverage for services related to non-medical needs, such as housing support or patients' inability to have consistent transport to get to their medical visits. And that can also make it really difficult to fully address social determinants, especially if we're not seeing them in our clinic. And then they're, you know, having difficulty not only accessing us, but addressing their sleep concerns. There's also a need for policy integration, and I think sleep health is not always prioritized in the public health, and when we're creating public health policies. And so really advocating for promoting good sleep in the community is a place that we can improve. And then patients and providers, they may not be unaware of how these factors can affect their sleep health. And so if we're not even, you know, sure how patients inability to get consistent, you know, rides to their doctor's offices is affecting their sleep health, or if a patient, you know, just doesn't have time to even address their sleep concerns because they can't get in to see their PCP. These are all opportunities that are, you know, missed opportunities for intervention, and should definitely be addressed. So Michigan, as a state, came up with ways to address social determinants of health. And so the Michigan Department of Health and Human Services came out with their 2022-2024 social determinants of health strategy, and they called it the Michigan's Roadmap to Healthy Communities. And essentially, this is a focused approach to help providers address social determinants of health and ultimately improve health outcomes and advance health equity. And looking through this proposal from the MDHHS, they have this visual representation here, which I thought was really striking. And so what we're looking at is the state of Michigan and the life expectancy at birth of patients who are born in different neighborhoods in the state of Michigan. And they found that a person's social determinants of health is so influential to their overall health that the neighborhood that they're born in is a predictor of how long they'll live. And so you can see here in Detroit, the red clusters indicate lower life expectancy in those communities. And so they found that life expectancy on average in Detroit neighborhoods was 62 years, whereas the overall Michigan average is 78 years. And the average life expectancy in Detroit communities are more than 20 years lower than neighboring communities 10 miles away, which is pretty profound and really, relevant for us, especially as a center that serves patients in Metro Detroit. So how did U of M kind of respond to this strategy? We have a Partners in Care questionnaire, and that was implemented, which is essentially a MyChart initiation that attaches questionnaires to the patient, and the patient ideally would fill it out ahead of time of their scheduled appointment. And if it's not done for an in-person visit, then the front desk would provide the patient with the questionnaire. Ideally, it would be answered and addressed by our social determinants of health coordinators before they even come in to see us. But most of the time, patients are filling out their e-check-ins as their appointment time is starting. So it's possible that you might see these questionnaires and not know what to do, especially because some of them, the patient has asked for resources. So I actually spoke to our social determinants of health coordinator, one of three, and she told me that initially the Partners in Care questionnaire was sent out only to primary care patients. And they found out that they were missing a large population of patients who don't have a primary care physician in Michigan medicine. They might only see specialty care providers, and they still have needs that aren't being addressed. And so they widened their patient populations to most of the ambulatory and specialty care clinics and the primary care clinics. They've remained in those, and they find that there are hundreds of these positive resource questionnaires that come through to these three social workers in baskets, and they have to address them. And they've really found that there's a stark need for a lot of these resources and connecting patients to the available resources in the community. So if you've ever seen one of these questionnaires, they look like this when it populates in your note. And this is from a patient that I saw a few months ago. And I wanted to go through these because sometimes, it looks really wordy and I'm not really sure what's going on here. So it's helpful to kind of talk through what we're actually looking at in this social determinants of health Partners in Care questionnaire. So it's grouped by different needs. And so the first one is virtual care. And it asks how well does the patient feel in terms of like their comfort level using technology to access their healthcare. This patient said she is not at all comfortable. And then it also asks, do they have internet access in their home to participate with the provider in the video visit? Do they have access to a device like a smartphone to allow them to participate? Do they need resources to get connected for virtual care? And are any of these needs urgent? So even though the patient was not comfortable with virtual care, she did not request for resources. And that's one of the things that our social determinants of health coordinator told me, is that if a patient says there is, something that they're uncomfortable with or that they're experiencing, but they don't want resources, they're going to respect the patient's decision. They won't reach out to them. So that's why each of these categories asks if the patients actually want resources related to that social determinant of health. Food insecurity. So it asks in the last month, has the patient worried about their food running out, or have they bought food and then it didn't last and they didn't have money to get more? For this patient, she said it was sometimes true, and she did want to get connected for resources for food, and she did mark that as an urgent need. Housing and utilities. Do patients in the last year have concerns that their utilities might get shut off because they can't pay for their bills? Or are they worried that in the next few months they might not have stable or safe housing? And for my patient, she said no to those. Healthcare and financial concerns. So do they need help getting in medical insurance, or in the last year, did they skip medications in order to save money? And patients can indicate whether that's yes or no. For transportation needs, patients are asked if in the last year they had difficulties with transportation that kept them from going to medical appointments or from getting medications. And then for child or elder care, in the last month, did having to coordinate care for someone else make it difficult for the patient to either go to work, to study, or to go to their own medical visits? And then for social isolation in the last 12 months, how often did they feel isolated from others? This patient said often. She did want resources for the isolation, but it was not an urgent request. And then the last two categories here, screening for intimate partner violence, and whether or not a patient has been forced to do something they don't want to do, or physically harmed in any way, or if they feel unsafe in the home or afraid of someone close to them. And then for job training, do they have a hard time finding steady work or a source of income that's steady? And do they want help with either getting in touch with a career center or with job training? And ultimately, for this patient, with the way that she answered these questionnaires, the care manager reached out to this patient, and she directly addressed her needs for food insecurity resources and social isolation resources. And that was through a portal message. And all of this was done within one business day because the patient marked her food insecurity as an urgent resource need, which I think is pretty phenomenal for our patients. And this was all done before, I saw the patient. And so that was also really profound, because this is something that is happening before we even see the patients, and it's already being addressed, and we're very lucky that we have this in place.
Can I ask you a question, Mavish?
Yeah.
Where do you find the outcomes documentation? Did you have to look hard for that, or was it like immediately apparent?
No, it was like right above like my visit. It was like right above or below my visit. So it and the like in my chart it said like something about like care coordination follow-up or something like that with the portal message. So it was very easy to see. I have another example here that's more recent. This is actually one of the patients that I saw with the fellows a few months ago. And this patient, I believe, was either 20 or 21, and also had multiple concerns with social determinants of health that might be affecting their health outcomes. So food insecurity was one of the ones that they recognized that they wanted resources for. Transportation needs was something that they recognized as a potential social determinant of health, and they did not want resources for transportation specifically. And then social isolation was something else that they recognized as a positive in this questionnaire. And then they also mentioned that they felt unsafe in the last year at home, or, have been afraid of someone close to them. Because this patient had, I believe, an adult that was still a medical proxy or could see their questionnaires, they are asked first, do they understand that their proxies can see the way that they're answering this questionnaire, and if they'd like to continue. So sometimes if patients don't want proxies to be able to access this, they'll just say no, and then the rest of those questions won't be asked. But they did not want to speak with anyone for resources about health, safety, or well-being. And this was followed up with a portal message shortly after from the care coordinators, and they provided isolation resources, food resources, and they also, at the very end of it, provided their direct number too if patient wanted resources for any of the other things that they recognized as potential problems with accessing healthcare or their overall social determinants of health. So one of the things, sorry to go back here, I wanted to mention, so anecdotally, when I was speaking with our social determinant of health coordinator, she told me that there are 2 departments in University of Michigan where the patient's social determinants of health questionnaires are usually positive for more than one category. And interestingly, that is the Kellogg Eye Center and our sleep department. So a lot of our patients have multiple needs that they are recognizing that are not, being met and they would like addressed. And so, this is an anecdotal thing that she's noticed, and I, told her that if there's research or anything that she's able to provide, objectively with data, that I'd be happy to, coordinate with her to see if that is true, and maybe sleep patients are more likely to have multiple social determinants of health that are not being addressed, and that is the reason why we're seeing them, because all of their sleep concerns are kind of being exacerbated by other things upstream that are not that are stressors in their lives. So something to consider too. So when we look at key points, what to take away from today's visits or today's talk. So social determinants of health definitely impact health equity and our patients' quality of life. And if we can integrate considerations on how to address these social determinants, we can profoundly improve a patient's health outcomes. Sleep providers can definitely impact sleep health, whether that be through community outreach or, having a seat at the table when public health policies are being discussed. That I think would be very profound. And I know some of our faculty have talked about public health concerns like, should we be everyone on like a standard time instead of having daylight savings time? And that is something that I've read, as an AASM statement as well, along with, later start times for kids in school to help promote better sleep and less sleep deprivation based off of their circadian rhythm. So those are ways that we've already implemented public health policies, but there's always room for more promotion of healthy sleep in the public. And then don't hesitate to rely on available resources here, and don't hesitate to reach out to them because they're very much open to collaboration. And I always am more than happy to discuss, any sleep related concerns in the primary care realm, or, if I'm set to see a patient a few months from now, but the referring provider has a question about the sleep study that came back that they have to manage. We've got a very collaborative approach here. And so we should rely on these resources because our ultimate goal is to provide that comprehensive, culturally forward, patient-centered care. And that's the motto, is the team, the team, the team. So references for this talk. And then I wanted to end with pictures of Aya. She is 1.5 years old. This is her last night practicing how to say cheese. And it was not her birthday, but it was a good time to walk around with a birthday headband. So I will stop sharing, open it up to questions, discussion, comments.
That was awesome. Thank you, Lowish. And I love that she has a Michigan medicine shirt. Open it. I have some questions, but I wait to see if anyone else has questions. I don't see any. There's some discussion about the Hope Clinic and some comments on your cute little baby. But great. I thank you for talking through that questionnaire because you see a lot of stuff imported in the notes, and it wasn't clear to me that those have been acted on. So we should assume, like, if things are answered in the affirmative, we should assume or trust, whatever the right word is, that these have been addressed by the system, or if there's something that falls upon us to address as well.
Yeah, that's a great question. And that was something that I directly asked our coordinator as well. And she said that the whole point of this questionnaire is to take any extra time off of the provider who's seeing the patient in addressing any of those additional resources. So even if they haven't talked to the patient in real time, because, you know, if patients log on and they've just filled out that questionnaire, it might populate in my notes that they need resources for food. And I don't necessarily know what to do with that. But then within 2 to 3 business days, if it's non-urgent, they will follow up with the patient. And that is their workflow. And they've confirmed that, you know, unless we want to put in the referral ourselves, they will see what we've done, and they will either re-refer or refer to the appropriate place if we put it in the wrong social work pool. But yeah, it is something that is taken care of and not necessarily something we have to address, even though it seems a little scary to not address something when patient says they don't feel safe at home in the last year.
There's a question in the chat from Megan. I don't know if you can see it or if
Yep,
you can
I
read
can
it.
see it. Let's see. Is there a flag for something like violence, sexual assault? Do you know if those are prioritized to be contacted ASAP? Yes. Great question, Megan. So yes, specifically, there are things that will be flagged as urgent, such as a patient who is 17 and under and needs any of those resources, or if a patient has marked that they have experienced IPV or intimate partner violence in any way, and those are automatically marked as urgent and will be acted on in 1 to 2 business days. Yes. So the anecdote about higher percentage of sleep and eye center patients about social determinants of health. So what our coordinators have found is that patients are more likely to have more than one category in that Partners of Care questionnaire where they say they need resources in that category. So whether that be transportation needs, food needs, or, you know, medical insurance needs. And they think that the reason sleep and the eye center have more of those patients where multiple needs are needed is because vision and sleep are very vital. And so if you're having a hard time with your sight, that can affect your job opportunity, your ability to get around. If you're having a hard time with sleep, because you might be, you know, someone who has extra stressors economically as well, whether that be instability from income or whether that be because of childcare concerns and having lack of support or elder care that you're responsible for in addition to, you know, your own care and needs. So I think that was anecdotally what she was getting at, is that sleep and vision are so vital, and our patients have multiple needs that might be negatively affected, either because of their loss of vision or absence of vision or low vision, or because of all of these social determinants affecting their sleep in a negative way, and that's why they've come to see us. But yeah, I think it would be really interesting to get some research going in that and see if there's objective data to back that up.
Yeah, I don't see any other hands up. Did anyone have any other questions? Or that was fantastic, Mahesh, and thank you especially for sharing concrete ideas and resources and talking us through so many of these really important topics. So great job. Thank you.
Yeah, of course. No problem. All right. Thank you, everyone.